on the programs. This has to be under general or regional anesthesia. Another option, well, for the Tapaja said most commonly placed 12 to 24 weeks. Another option would be progesterone supplementation. So we can do medication. In single gestations where there's no history of preterm birth or labor, this is an option that is commonly recommended. Progesterone has been known to preserve the length of the cervix and lower the risk of having the baby too early. It comes in topical gel, suppository, and there's also intramuscular, but the more common is the actual vaginal applications, which the mom would put in daily. You could also try pressuring, which can be placed to support the cervical closure and lessen pressure on the cervix. This can be done in the office without anesthesia. So some of the signs and symptoms, kind of similar to what we've already been looking at: abdominal cramping, abdominal pressure, diarrhea, pelvic pressure, backaches, menstrual-like cramps. There may be a mucus plug that's released from the cervix, bloody show, and early dilation and effacement. That is the preterm labor. So those are your signs and symptoms of preterm labor. Evaluation. We want to monitor contractions, and we discussed methods on Tuesday, the electronic fetal monitoring and topo monitoring. Topo monitoring was when they put the belt over the fundus, and there's a transducer there that is calculating the contraction, the frequency, and the duration, and it's monitored on graph paper or the monitor itself. And then we had some other types of fetal monitoring, the fetal scalp and the intrauterine pressure catheter. Of those three, the topo, the intrauterine pressure catheter, and the fetal scalp, which one can you do with the amniotic sac has not broken? Topo. Remember, do not do internal monitoring if the amniotic sac is not broken. Do not do that. The exam, we're going to do a speculum exam for preterm labor, visual exam. We're looking for premature rupture membranes. We're looking for uterine bleeding. We're looking for cervical dilation more than 3 centimeters. More than 3 centimeters. That supports the diagnosis of preterm labor. While we're there, we're going to obtain cultures for group B strep and STIs, as infections can be a cause of these, and we want to treat accordingly or be ready to treat for delivery. And then there's something called fetal fibronectin. And fetal fibronectin, we're going to talk about on next. Clean catch urine, you can do asymptomatic bacteria, increases the risk for preterm labor. And then we can do a transvaginal ultrasound to measure the cervical length, measure the gestational age, presentation, and placental location. So the fetal fibronectin, this test detects fetal fibronectin, which is in the vaginal fluid. This helps us determine if the mom is at a short-term risk of premature labor or premature delivery. So if you look at that picture at the top, basically the protein is produced at the boundary between the amniotic sac and the lining of the mother's uterus. And that is basically the fluid that kind of keeps those together. So it's only found there in the vaginal fluids in early pregnancy and when it's almost time for mom to give childbirth. So if they find that on exam, then that is an indicator that mom may go into premature labor or may have a premature delivery. Usually detectable between 22 and 35 weeks in that. Diagnosis: regular painful contractions. Regular painful contractions. Remember, with false labor, Braxton Hicks, irregular. These are every 4 minutes, every are more greater than or equal to every 4 contractions every 20 minutes, or 8 or more contractions every 60 minutes. Remember, the cervix is dilated 3 or more millimeters. And there are certain findings you would see on transvaginal ultrasound as well. Management, we want to try to treat it. We don't want mom to have the baby at that point if we can help it. So like I said, all moms who are symptomatic do not necessarily go on to have the baby. Some of them will go to full term. So if we can treat it, we can. First, we want to do some IV hydration while mom's there. We talked about corticosteroids in the hormone lecture. And what we know about the corticosteroids is they help speed up lung development, and they help with the synthesis of surfactant, which we talked about we need so that those alveoli don't collapse when the baby's breathing. So we will give betamethasone if the mom is 24 to 34 weeks. Because we're probably going to go ahead and deliver. With corticosteroids, they usually take action about 24 hours to 7 days. So if mom is in preterm labor, we can hold off that labor. We would give the betamethasone in hopes of increasing the surfactant to mature the baby's lungs a little bit faster. We want to speed that up in case the baby comes on and enters the earth. So we want to provide that for mom. And then we also talked about tocolytics before. These help reduce uterine contractions and motility, so we may give those so mom stops contracting. One of those tocolytics we talked about was mag sulfate. Terbutaline is another. Vidipine is another option you can do to reduce contractions. So we have a couple of different options there. Mag sulfate, vidipine, and terbutaline, all are tocolytics. Help relax those uterine muscles so they don't contract. Opposite to which treatment we give to make uterine contractions. Pitocin. So this can delay the labor up to about 48 hours, provides a window to administer the corticosteroids, evaluate for group B strep, or treat group B strep if it's there, and hopefully have a baby, even if it's a preemie, that has more mature lungs, so that they don't have to experience that respiratory distress. Some of the contraindications, who you're not going to give tocolytics to. Well, if the fetus is mature or if this is an advanced labor, we don't want to give those. If there's any type of intrauterine infection, we don't want to give those. For mom, if she's having significant vaginal bleeding, we don't want to give it. And then with the medications for the magnesium sulfate and then the vidipine, there are also contraindications for that. Yes, sorry.
So if we was both more
We treated moms.
so let's say the baby
Get born,
is born and like
then their baby's gonna go to NICU. They're gonna do treatment there to help mature the lungs there.
big difference. So,
I'm not for sure, but I think there are steroids. I don't know if they know. Surfactant, just surfactant, yeah. So that's gonna be for the fact that they mentioned was creating the. All right, premature rupture of membranes. So, premature rupture of membranes, talked about rupture of the fetal membranes prior to the onset of contractions. If the rupture of membranes happens before the contractions, before 37 weeks, that is a preterm premature rupture of membranes, PPROM. If it's after 37 weeks, it is just premature rupture of membranes. Typically, you would have the contractions, the rupture of membranes, but if you have the membranes rupture before the contractions, this is what we call a premature rupture. It's about 8% of pregnancies Management, we initiate delivery, and how do we initiate delivery? How do we induce? What medication? What's the difference between induction and augmentation? Anybody remember? Augmentation, mom's already having contractions, we're just trying to speed those contractions up, speed up the duration, speed up the intensity of those and get that baby going. So augmentation, we're kind of augmenting what's already happening. Induction, we're starting it. These patients may also have to have a cesarean section. Labor is induced immediately unless a vaginal birth is contraindicated, which in that case with us. Just some statistics, 3% of pregnancies frequently leads to preterm labor and delivery, may lead to intrauterine infection because the amniotic fluid is seeping out, okay? It's there for your amnionitis. Some of the risk factors, nulliparity, infection, smoking. Cigarette smoking is probably one of the bigger ones for preterm premature rupture membranes. Keep that in mind, when you're educating your patients. Signs and symptoms of a preterm premature rupture of membranes, a sudden outflow of clear or pale yellow fluid, small leaking sensation, abnormal wetness, provoked by Valsalva. So most patients aren't doing Valsalva, but they are grunting, they're bearing down on the toilet. So if she's having a leakage, like she's restroom, maybe she's having a bowel movement, that may be a sign. Pooling of fluid in the vaginal wall, which you're going to see on your ultrasound, they may have polyhydramnios because the amniotic fluid is already ruptured, so there may not be enough fluid around the baby. I don't like that TX, I should have changed it. It's not really a treatment, part of the diagnosis, it might be mainly burn test. Let's use T for testing. And we talked about those. Last on Tuesday, when we were talking about premature rupture membranes. The nitrazine and the burn test. Remember, the nitrazine is that pH test. Anything around 7 to 7.5 is indicative of amniotic fluid. Okay, on the next page. I'm gonna go over that, when I did it Tuesday. We review that.
Such a me.
Management is multifactorial. Several things you need to consider or do. They want to check the amniotic fluid index. Remember that it's between 5 and 25. Over 25 means too much fluid. Under 5 means not enough fluid.
Yeah,
They need to do a PCP on the baby, a biophysical profile. You'll see cervical changes on your specimen exam. There may be presence of infection. So a lot of things you have to consider here when you're assessing and how you're going to treat. You might have to induce them. You may have to go ahead and deliver the baby, or C-section may be necessary. Meconium, this is fun stuff. Looks pretty gross. That's your first fetal bowel movement. So the initial substance is present in the intestines of the fetus and passing after birth. It should occur within the first 24 to 48 hours. If the intestines are intact and patent, it comes right on out. That first diaper phase is, yep, it's black, it's brown like that. It can be green or yellow too. Most of the ones I've seen look like tar. I used to volunteer in the newborn nursery. It look like tar and they're sticky. If the baby has a delay, they do not pass that meconium within the first 24 to 48 hours. That may be an issue. That may indicate disease or some type of obstruction. And a lot of preterm infants have a delay in the passage of the meconium. So keep that in mind. Meconium is also sometimes noted within the amniotic fluid. We see this in up to 20% of deliveries. Basically, the fetus had a bowel movement inside of mom. And if we have that amniotic fluid is brown or discolored, it should be clear or straw tinged. But if there's meconium within it, it's discolored, it's brown or green. And what do we know about babies and their amniotic fluid?
Swallow it.
they drink it, right? They're not going to grab a bottle, so they're going to drink it, and that's a problem. Because meconium can be in the oral pharynx when they're delivered. So if they are testing mom and they note that that amniotic fluid is discolored, they're calling the resuscitation team to be on call. They're ready, on standby, ready to go to help clear those passages so that baby does not aspirate. Okay. The baby is hypoxic, the anal sphincter relaxes, which allows that meconium to pass into the fluid. Again, the fetal airway will need to be cleared to avoid aspiration. This poor little baby is all stained with meconium. Meconium aspiration syndrome, the diagnosis in newborns, born through meconium stained amniotic fluid. It can be life-threatening. For treating with respiratory support, ET intubation. If the baby's gasping or having labored breathing or any type of poor oxygenation, which is why that resuscitation team is on standby. So we have talked about fetal heart rate monitoring before. So if we're detecting fetal hypoxia, that could be because of meconium. That's one cause. All right, let's talk about hemorrhaging. So some of that just kind of like overlap. We've already talked about it, so should be just a review. We're not gonna spend a lot of time there. All bleeding in pregnancy should be promptly evaluated. Remember, everybody with vaginal pain and bleeding needs to be evaluated. Vaginal bleeding needs to be evaluated in a pregnant person. So, this can be an obstetric emergency in the third trimester. The most common causes are placenta previa and placenta abrupta. Placenta previa being painless, placental abruption being painful. Different types of placenta previa, we discussed. Abruption, the separation of the placenta from the uterus. Most accurate diagnostic tool is ultrasound, but there is another placental complication we want to add to the list, and that's placenta accreta. That is when the placenta is too deeply attached to the uterus. So typically the placenta is attached to the lining, but with placenta accreta, the placental cells go in a little too deeper and they start to attach to the actual muscle. So typically after the baby's born, remember we talked about that involution of the uterus and all those things that happen in that third stage of labor, that placenta should come from the lining and we should deliver it. But with this one, the placenta is not coming out. It is stuck. It is deeply embedded into the muscle. There are three types. Placenta accreta is the most common, but you also have increta and percreta, which depends on how deeply involved it is into that muscular layer. This is a high risk complication because it can lead to hemorrhage. A placenta accreta, that is our third placental complication. Placental accreta risk factors are a prior C-section or uterine surgery, so you might see that in women who've had fibroids. Of course, placenta previa it's a possible cause. That placenta is hanging over the os and it may start to embed into that tissue. It usually can be found on ultrasound if you're doing good antenatal care. We talked about those frequent ultrasounds and things like that. Some of the first signs and symptoms are bleeding. Vaginal bleeding. At the time of manual separation, there could be a profuse hemorrhage, which is why this can be emergent. Unfortunately, for this one, usually they recommend a C-section and do a hysterectomy after delivery. Not always. But because there is excessive bleeding, a lot of times they just take the whole uterus out with the placenta inside. Versus just trying to take the placenta out and cause even more bleeding, can be very dangerous. So with that one, that means moms cannot have any more babies naturally if they choose that route. Sometimes they don't do the C-section and immediately after delivery, the daughter come back in a little a couple of weeks or a couple of days, depending on the mom's situation. But typically, these patients are gonna be admitted to ICU for close monitoring. In some cases, they'll do the C-section later. In some cases, the uterus, the placenta will fall out random after a few weeks. So they can also go in after they've gotten mom stable and just take the placenta. So it all depends. This is not anything I expect you to see on your rotation, but you should be aware of it. It's not very common.
Right,
Yes,
but that is the bleeding prior to delivery or is
yes,
it's prior
prior
delivery?
to, and then when they try to separate it, then there can be profuse hemorrhage. But yeah, there is antepartum or prenatal. Exactly.
Okay.
So this is like your patient comes in, bleeding, you're not for sure where it's coming from, you're checking for a previa, you're checking for a previa, you're checking for eruption and other things that can cause vaginal bleeding. So we can do that with, let's see, what's the, well, at the time of the, at the time of the birth, they're gonna have a hard time getting that placenta out. Other causes of bleeding, uterine rupture. Usually there's a prior uterine scar in these cases. So with the delivery, might just be too much pressure on the, maybe it's a scar from fibroids, or maybe it's a scar from a previous C-section, and it ruptures that scar. So you have a uterine rupture where the uterus just is torn. Fetal bleeding can be secondary to trauma. Fetal bleeding can also be from a fetal bleeding disorder. Fetal trauma, typically motor vehicle crashes, cause a baby to bleed, and then mom to bleed. Trauma is the leading cause of non-obstetric death in an expectant mom. Trauma. Car crashes first, falls second. Moms walk different, their stability is different, they fall easily, baby gets hit, bleeding can be very dangerous. Postpartum hemorrhage from acne is another cause. We're going to talk about uterine acne a little bit more on the next slide. This is when mom has a blood loss of more than 500 cc's at the time of delivery. So acne is the uterus not contracting like it should. We kind of talked about that on Tuesday a little bit. Uterus is not, your body's releasing oxytocin to make those contractions go, but the body's not reacting to it, and it just kind of relaxes. And we talked about that can be from exhaustion. We talked about different causes that may cause that to happen, but it can also lead to postpartum hemorrhage because you need that contraction to stop the bleeding. Treatment, infusion of oxytocin. You're gonna get that through IV. Prostaglandin analogs, we talked about those as well. Those help with cervical ripening, which is softening the cervix. If we soften the cervix, just like if you were having a normal pregnancy, your cervix starts to efface, softens, gets shorter, and that promotes contraction to have the baby. So you give prostaglandin, it kind of works in the same way. It'll soften the cervix and promote those contractions. You can also manually stimulate and contract the uterus. If the mom is not responsive, they may need surgery. You might have to ligate the uterine arteries or if you look at surgery. This is very rare in vaginal and cesarean sections. This is uterine inversion. So the uterus is completely or partially turning itself inside out. It's crazy. This is life-threatening. It can lead to severe hemorrhage and shock. So it is an obstetric emergency resulting in maternal death. It's the definition again there, post your pictures. If the fundus isn't able to contract, it can exacerbate bleeding when the placenta is trying to separate, which can lead to the lighter inflammation shock. Bless you. Why don't we, first we're gonna, usually when you hear dystocia, it's with shoulder dystocia, but definitely dystocia is a difficult or obstructive childbirth. This is often due to slow dilation of the cervix, slow descent of the fetus, it's taking its precious time coming out during active labor. Entrapment of the shoulders, that's our shoulder dystocia after the delivery of the head. So they got the head out, but they cannot adjust the shoulders. Abnormal lie or presentation. And we talked about lie, presentation, position. We talked about our 5 P's in labor. Lie, remember, lie, L, longitudinal. So we have longitudinal, that's related to the long axis, lie, long axis, longitudinal. All start with L. That's the relationship of the baby and the mom to each other's long axis. Is the baby longitudinal? Is it oblique, sideways, or is it transverse, completely straight across? There may be size disproportion because of the fetal head and pelvis. So we talked about pelvis shapes. We talked about the baby's head and attitude, chin flex, chin sunny side up with the face first. All those things can change how the baby gets through that canal. Common complications of dystocia, brachial palsy. Injury to the brachial plexus can cause a loss of ability to flex and turn the affected arm, which usually for most babies will resolve in a few months. But if it is actually torn while they're trying to deliver the baby, that baby can have permanent loss of movement of the affected arm. There may be cephalopelvic disproportion, which we talked about. Which condition did we talk about creates big babies? Gestational diabetes. Something like that has nothing to do with gestational diabetes. Babies just might have a big head. You know, the baby's head is too big, or mom's pelvis is too small, or just the presentation of the baby. We may have some problems fitting it through the pelvis. That's where your assessments come in. We're going to be doing pre-labor and delivery assessments to screen for that disproportion. Remember, we're doing Leopold, we're checking engagement, we're checking presentation, we're checking to see if the baby's breached. Does the baby have a foot wing, an incomplete breach where just one leg is up? Different position changes for both. And maybe we can make some adjustments or plan for a C-section if necessary. With these babies, the labor does not progress. So the mom stops dilating, the baby doesn't come through. And a lot of times, if the pelvic outlet is insufficient or just not big enough, they will proceed with C-section. All right, when you come back from your break, we will do operative deliveries. So we'll talk about forceps, vaginal, and cesarean section. We'll finish this, and then we'll go to operative vaginal delivery. And sometimes we have to use forceps and vacuum extraction to do this, as well as C-sections if we're having trouble getting the baby out or if there's any type of fetal distress. Surgery is typically our last option, so if mom is not able to deliver the normal route, vacuum extraction and forceps deliver additional ways for us to deliver the baby. Some fetal indications may include a non-reassuring tracing or a non-reactive tracing. Remember that. Maternal indications can be exhaustion. Mom is just too tired. She can't do it anymore. I've been in labor for 36 hours. I just can't do it. I'm trying and I can't get it out. They may have to help mom get that baby out. Does anybody remember what is considered prolonged labor in that second stage?
More than 6 hours?
For a multifarious mom, it's more than 2 hours. If it's a nulliparous, who's never had a baby, it's more than 3. So remember, the first stage can be 20 hours, 14 hours. The second stage should just be about 3 or less for a mom that's the first time mom. And if you've had babies before, it should not be more than two. So if we're seeing so long
Smell
labor, these are things that we need to consider. So we'll look at four steps first. These have fallen out of favor among obstetricians over the last 30+ years. Four-step deliveries make up about 0.5 to 1% of vaginal birth. And as you can see in the picture, they're using a four-step to provide traction and help rotate the baby's head. It's not look fun.
No.
It is indicated in a prolonged second stage, as well as if there is suspected fetal compromise. The baby's head must be engaged for you to use forceps. And what do we say engagement was? What station? 0 or higher positive numbers. Remember, negative and positive numbers for station. So baby must be at least, it must be above 0 station to do it must be a 0 or higher, which means +1, +3, or lower. If it's up higher and it's just free floating in a cup, cannot use forceps to get that baby out. This is associated with a higher maternal mortality. So this is more dangerous for moms. Vacuum extractor, basically, if you look at that picture, the second picture, they're putting a suction on top of the baby's head and using traction to help pull it out while mom pushes. It has also declined in use. It is easier to use compared to forceps, but it's less likely to result in a successful vaginal delivery. So if they try the vacuum, sometimes they still have to go to C-section. This one has a higher fetal mortality. So forceps, higher maternal, vacuum, higher fetal. And what do we know comes with higher fetal and maternal mortality rate? Lawsuits.
Yeah, it's true.
Lawsuits. You caused my baby brain damage. You killed my wife while we were trying to deliver this baby. So these assisted deliveries have fallen out of favor, which is why on Tuesday, right after lecture, the night of lecture, I see a story on Fox News that says cesarean sections have gone up to 30% in the United States. This is probably why, because of these lawsuits. Just on the news on Tuesday, so the increase today, there's a big concern about the increase of C-sections in the United States. The World Health Organization said it should be about 10 to 15%, and we're at 32. A lot of C-sections. C-sections probably pay better too.
Yeah, for sure.
Easier to
And you
schedule.
can plan people to
Don't
go
want
on a
C-sections.
video
I'll talk about C-sections next. So
Yeah,
C-section. This is the most common operation performed in the United States. And like I said, it's at 32%. When Professor G did this, it was at 25%. I changed the percentage, so it's changed.
You gotta push them out.
The hospitals that offer OB services must be able to perform an emergency section under 30 minutes. So they have their own requirements. What are some of the indications for a C-section? Those before prolapse. We talked about the baby's big head. Big body can't get through, small pelvises, that's the fallow and pelvic disproportion. Our placenta previas, our placenta abruptions, that can also be indications for C-section. And then fetal malpresentation, baby's transverse lie straight across. You're not gonna be able to get that baby out of the pelvic inlet. You're gonna have to do the section for that. So other hands on the side, non-recurrent fetal heart rates. Not sure what's wrong with baby. We talked about that when we talked about Serena Williams. That heart rate was just dropping. I'm concerned about hypoxia. You're gonna probably need to get a C-section though. Uterine rupture, we just talked about. Preeclampsia with severe features. Multi-gestation. Almost impossible for moms, non-tablet moms to have those babies. Multiple gestations with 3 or more C-sections. Other possible indications, HIV is treated, or if there's a high viral load, we don't want to transmit to the baby. Late term or active genital herpes infections, don't want to transmit to the baby. Uncontrolled diabetes is also another possible indication, right? Certain. C-section reasoning, is it a benefit to the fetus? Why do we do them? Sometimes fear litigation, like we said, malpractice, lawsuits, come with those other assisted deliveries. Social preference. Social preference. A lot of people are scared. I fear the pain. I don't know if I can take the pain. Can we just do a C-section? And some people will oblige to that. There are also, because of C-section and being able to give a preference on a date, people get to pick the birthday. So there's been studies in California that show Chinese Americans have their babies on the 8th, the 18th, and the 28th. The 8th is a lucky number. So they've shown an increase in that, because they decided, I want to have a baby on this date. If they're, I prefer to have a C-section, then they choose the first date if they're 82. Also, women don't want to have babies on Friday the 13th.
Leslie could never transfer care to anybody.
You know, there's some of the causes, impositions,
She was like,
negative previous, I had a terrible vaginal delivery, can you just please do a C-section? And clearly, by the rates, the providers are obliging, so. There are some good things. Perinatal mortality is decreased for infants born via C-section. So, you know, there's a lot of things that go into choosing whether or not to move forward with it. Some of the indications, dystocia, if you've already had a C-section, a lot of times they'll just go ahead and repeat another one through the same incision. Does anybody know what a VBAC is?
Vaginal birth after.
Yeah, vaginal birth after C-section. Everybody doesn't have to, some women can trial a vaginal delivery after a previous C-section, but sometimes that does come with more complications. We talked about that uterine scar or a C-section scar rupturing, so uterine rupture can occur. When babies are breached, their booty first, foot first, then they may need to have a C-section, fetal distress, any type of cord prolapse, the cord is just stuck, trapped around the baby's neck, they can't get it out, and they have to have emergency section. And pregnancy is complicated about previa. Remember, we are not gonna promote that vaginal delivery because that pressure is gonna possibly lead to hemorrhage. The placenta and it's overlying the os. So if you're pushing that baby through those blood vessels, that mom might lead to that. With no placenta, so if you're not doing a vaginal work on placenta previa. Uterine rupture, we talked about. This is rare, 1% of women. Happens in 1% of women who try to do a vaginal birth after a C-section. So it can be from a previous C-section scar, any type of uterine trauma, accident or surgery is the cause of the makes of women at higher risk for uterine rupture. There can also be a congenital uterine anomaly where there's basically like a septum, a wall dividing the uterus that causes them during labor to, that septum causes tears during the labor because of pressure. Those things, again, not very common, but you should be aware of them. Emergency C-sections are needed to prevent life-threatening complications. What is a cord prolapse? Well, this is when the umbilical cord travels through the cervix and into the vaginal opening after the rupture of membranes before the fetus even descends into the birth canal. As the labor goes forward, that cord is compressed by the baby's body. You see the little cord sucks the baby going down the cervix. Now baby's coming down and he's smashing it or she's smashing it. This can lead to decelerations. We talked about accelerations and decelerations. We said there are 3 types of deceleration: early, late, and variable. I showed you an acronym, Bill Chop Mine. BEALCHOPMINE. B, variable, cord prolapse. The C, for chop. The M, managed with maternal repositioning or delivery of baby. The E, early. The A for acceleration, the late for P, the pauses, and the management. Maybe that's such a cord prolapse. It would be a variable deceleration, but we talked about the decelerations and what they look like. Early, matching the contraction. Remember, it goes down that nadir, that peak of the bottom of the fetal monitoring, the bottom of that heart rate goes down as the contraction goes up. With late, the bottom of it is after the peak of the contraction. With variable, it's all over the place. Remember, with a variable, it looks like letters. V for variable, looks like V, looks like W, looks like U. Okay, when you're trying to remember what is a variable, what is the early, what is the late. The V looks like letters. Think V for variable, it's V shaped or W shaped or U shaped. It does not match, it varies, it doesn't match the contraction. That's for prolapse. The way to remember it. Cesarean deliveries. So for most cesarean section deliveries, they are going to do a low transverse incision, which you see over on the top. That is the most common, the most preferable incision type. It has a lower risk for uterine rupture. The scar for moms is prettier, it's right along that bikini line. That's what the one they want, they can be covered up. There's also a classic presentation, which is a larger scar. If you have a classic incision, you have to have a C-section again in the future. You're gonna use a plastic incision in those transverse live babies that really just sideways. You might do that procedure for them. Any type of emergent situation, they probably will pick the plastic if it's extreme emergency, just to get the baby out. There's also a low vertical, which is on the top right-hand side. They sometimes will use this in breech babies. So again, if you get a low transverse or a low vertical, the possibility you can have a baby vaginally after the VBAC. If you have a classic, you have to have a C-section in the future if you get pregnant. Graphic picture, baby coming out via C-section. And then we have external cephalic version, which is basically turning the baby. It's the procedure to turn the baby from breech to cephalic or vertex, which is what we call head down. It is most common for babies in breech position. And babies breech before they go for the C-section. Remember, C-section is gonna be your last option unless baby's in transverse lie and sideways. They're gonna try to turn the baby. So they usually will do this around 36 to 39 weeks, not very comfortable for mom, but will help prevent a C-section. Usually has a 75% success rate. So they're gonna move the baby, then they're gonna do a sonogram to check the position. Leopold also checks position. This is just a picture of that. And I think I left you a YouTube link so you can watch your doctor actually move the baby from breech to head down. I didn't embed it into the thing because usually when I embed my slide, I'm like, you can look at it on your own if you're interested, but how they will turn the baby to get it down. There are postpartum infections we should be worried about, or at least be on the lookout for. UTIs from distended or delayed emptying, distension or delayed emptying, sorry. When moms are catheterized, if there's any type of trauma during the delivery, UTIs are a possibility. Wounds, we talked about episiotomies last Tuesday. Lacerations, if there's C-section, now you have a wound, you have to look out for postpartum infections with those. You're gonna talk to mom about what to look for. Is it red? Is it warm? Is it oozing? Those types of things. You do your repairs on your lacerations, same thing. Is it red? Is it warm? Is it oozing? Other signs of infection, fever, like you're gonna talk to mom about that in your education. What can put mom at risk for these? Intrauterine monitoring. We talked about an internal fetal monitoring that we might do for fetal heart rate. Serial vaginal exams during labor. They're constantly going in there. Checking, looking, what is your dilation? What are your defacements? Feeling a lot of hands going into the vaginal area and a potential for infection if they are not practicing universal precautions and food hygiene. Retained placenta. Some of the placenta is left. We talked about that on Tuesday. Looking at the placenta front and back, looking for missing pieces, making sure all the edges are there so that mom does not have bleeding or infection. And then premature rupture of membranes over 24 hours can lead to infection. mercurial amnionitis. One, inflammation or infection of the breast is lactational mastitis, which is something moms should be aware of. This is a localized inflammation of the breast with or without infection. With or without infection. If they have infections, likely due to Staph aureus. Staph aureus can grow in the stagnant milk if mom's plugged and her milk won't come down. Staph can grow in there. Lactational mastitis is most common in the first 6 weeks postpartum. The breast is gonna be firm, it's gonna be red, tender. Mom might have fevers, chills, muscle aches. This is a clinical diagnosis. If severe, you can send the milk off for culture. Treatment at the bottom. That cloxacillin, complete emptying of the breast, gonna encourage her to pump, 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 get rid of that milk. Symptomatic, with pain reduction and cold compresses treatment, you would, consider those as well. Another rare catastrophe is amniotic fluid embolism. You can see the percentage there, it's 1 out of 40,000, so unlikely in your life, but should still know about it. This is when amniotic fluid, fetal cells, fetal debris, hair, something enters mom's pulmonary circulation. And it causes like an immune reaction that basically puts mom into what seems like anaphylaxis. It's very emergent once mom is symptomatic. It can cause cardiovascular collapse. 50% die in the first few hours. So if you see any of these after the baby is born, anxiety, impending sense of doom, nausea and vomiting with chills, loss of consciousness, seizures, cardiac arrest, of course, those are big no-brainer. Stroke, brain damage can occur. BIC might be something you see, excessive and uncontrolled bleeding. These are signs and symptoms of an amniotic fluid embolism. You cannot prevent it, and they don't know why it happens. It is a diagnosis of exclusion, and autopsy is the means to confirm. In most cases, there's a link there for the Amniotic Fluid Embolism Foundation if you want more information on that. Question? Yes. There's inflammation with or without infection. Non-infectious might be like a foreign body reaction. Infection usually can't bother. Not necessarily. You might want to go ahead and treat. No, you just said it. It was severe enough, you would just send it, but usually they're gonna have to start to pump, see how she get, once she gets it, try to empty breath out. And if that helps improve it, then you're gonna be. But if it's severe enough, that treatment isn't working, then that on for the rest. Yes.
It may be different based off like practices, but
Yeah.
I know for us, if they had any systemic symptoms like fever, chills, we would just send the dicloxacillin. A lot of like your community pharmacies don't really even carry it. So if it gets better in a day or two while they order it, then okay, you don't have to take it. But if it's still bothering you, we have to take it.
Were you able to hear her? Another question?
Yeah, I was gonna say, like, we don't have any treatment for, like, if it's amniotic fluid embolism. We have TPA for toxins.
You have TP what?
Like, we have TPA for toxins or something.
I mean, you would go ahead and try those things. If you're, whatever the condition you're trying to, you know, you're gonna go through your same protocol, but you ask for a stroke, cardiac arrest, for those things, you're gonna go through, those things that you can't prevent. If they don't know why it's causing, you can't necessarily prevent it. Once it happens, you need to treat that aftermath of whatever. Because it may not even be here. And the immune reaction, the body mothers are maternal and the immune system is more crazy.
Yeah, today there's learning. It happens Because I think it's very common.
what the ovary produce and
What?
what the whole process is of the menstrual cycle and reproductive cycle. We talked about this the first day. FSA, LH surge, when estrogen and progesterone, are released, why they're released, because we need to understand the contraception, which we've already talked about. This makes me think of something that I didn't talk about, the twins that I meant to, talk about. If you have time, I want you to look up superfundication and superfetation and superfetation, I think that's how you say it. So superfundication is when we have a baby, when you have twins by two different fathers, or
No.
that's so cute, which is super rare phenomenon.
That's
Rare
crazy.
phenomenon.
You know.
What a dog.
Yeah, what a dog.
This
Shut up.
It's a party family.
Something I
That
call
is
that.
so
It may not
sneaky.
sound
Yes.
Yes.
Who's your daddy? Who's your daddy?
All from different dads?
No, they're from the same dad.
Two or more
Like, I think we're ovulating, and they would deliver it is fine.
And then just fertilize on the
Wow.
plate.
Biological father.
I love that.
That is some crazy shit.
If a woman has intercourse with two
Super.
men in a short period of time while ovulating, it's possible that both men can impregnate her separately. Two sperm, two different sperm impregnating two different eggs.
Is that the word I want?
Very interesting.
You did not just say that.
Very, very. And superfetation
I said, I want to play the
is,
field. I
Um.
don't want to be tied down to just one person.
What, superfetation?
Yeah, the one baby dog is being.
Superfetation, yeah, that's it. So superfetation is when you're pregnant and you get pregnant again in a couple of weeks. So your babies are on two different paths, so they'll see, oh, you're pregnant, see the yolk sacs, and then you go back.
I don't know what to say.
Serial
Equals.
ultrasounds, they're like, oh, we see two babies and one's at a different, it wasn't hidden necessarily behind the yolk sacs at a different, it's measuring at a different age. And that's consistent. So that's very, very
No,
rare.
she's
There
not
was one
born.
lady who had one.
Busy, hard worker.
She was pregnant, and she got pregnant 3 weeks later. So she was pregnant with babies at the same time.
This is
Two
not
different.
that far off.
That's not that far out. Yeah.
There's a girl, if anyone's interested, it's called Taming Triplets.
Yes.
It's
I'm
on
interested.
TikTok. But I'm chronically on there, I'm sorry. Her name is Charlotte, she's in California, and she has triplets. Two of them are like identical twins, and then the third baby was 4 weeks behind. And they delivered, it's same dad, but they all delivered at the same
Dang,
time.
throw that in there.
Same father, and she just had a son, like a few months ago.
Four?
So she has 4 kids under 2.
The one that I saw her story, she had, another baby at 16 weeks, so she had her twins that were different.
Roommates.
Roommates.
That's crazy.
So yeah, those are rare phenomenons. I had it listed in my notes, but I forgot to talk about it, and then I was like so scared I was gonna run out of time, so this reminded me of that. When we're talking about reproductive cycle and trying to prevent eggs and sperm and all of that stuff from working together.
Sending us a farewell.
All right, we've seen this before.
I was farewell.
From this row, from
Who
this
sent that?
slide
The
to
university
the,
just said farewell and congratulations.
previous
Oh,
slide.
I wish.
So, ovulation, fertilization, implantation, those are our normal events of pregnancy. Where do we say eggs are mostly fertilized? Ambula, you got it. So how does contraception work? There's some different ways. Contraception, all contraceptives prevent the fertilization of the egg by the sperm. So we can prevent ovulation. We can thicken cervical mucus. We can block the sperm. We can incapacitate the sperm with the proper IUD. And those cause like an inflammatory reaction and basically kill the sperm. Like toxic to the sperm. So we have different options, and you can see the different options underneath what they do, what options you have. So you might try the hormonal contraceptives, combined oral contraceptives, or the implantables for preventing ovulation, thickening the cervical mucus. We have different options. The only ones that block the sperm are the condoms, male and female condoms. So I'm gonna talk about these family plans.
Is that what you do?
is what we want to talk about first, because
Give Brendan.
family planning isn't just about preventing unintended pregnancy.
Oh,
Um, The thought behind family planning is that we want to optimize pregnancy outcomes as well, help people reach their reproductive goals. It's not always just about prevention. They have done a lot of studies and they are very, very happy in terms of what we have done in the United States in terms of family planning, same on par with like vaccines and things, they put it up that high because they've been able to determine family size, which they say improves health, improves well-being, contributes to healthcare and our public healthcare. A lot of different factors in terms of the person being able to plan their family. Choosing a method of family planning, unintended pregnancies reported by women as being mistimed or unwanted. That is an unintended pregnancy. These are just definitions. 3 types of interventions. You might do contraception, which prevents fertilization, interception, which is the fertilization, but prior to implantation. That's gonna be like your emergency contraception, morning after pills, and then abortion, which is an interruption of the established pregnancy. Another one that is not listed that I think should probably be included is abstinence. If you're not having sex, you can't get pregnant
Correct.
unless it's something miraculous.
She was the liar.
So our primary
Mary
focus
was.
as we're doing
Mary
family
was a
planning
whore.
You both.
is to
talk
respect
about, I want to
the
see that.
mom's preference
I
and
got it from both of you on the same day.
It's kind of good.
Right.
when we're choosing a method of family planning, we have a couple of things we're looking at. Ongoing contraceptive methods, so is it a reversible or is it permanent? The effectiveness, we look at 2 numbers, the failure rate and typical use failure rate. So failure rate is when the patient is using it just by the manufacturer's recommendations. They're using it consistently and correctly 100% of the time. And we know that that's not the case for most people. So our typical use failure rate takes into account improper or inconsistent use. These are our real world values, our real world users. Surprisingly, about half of all unintended pregnancies do occur among women using contraceptives. You know, a lot of people.
I know, isn't she?
Things just happen. We also want to look at cost. Is it cost effective? Is it too expensive? The ease of use. Is it easy enough to just put a condom on? Do you need to go and put in a female condom? Do you need to go do a, spermicide on this and do that? And it's a lot of different things. So how easy is it to use? And then what are the side effects? It's gonna be our big one because that's why most people will stop. I'm not taking this anymore. It makes me sick. I'm too nauseated. I'm bleeding all over the place. I haven't stopped bleeding in 30 days. So these are just resources. Of course, you don't need to memorize a lot of the stuff, but reversible contraceptives, we group them into 3 tiers. So you need to be familiar with the tiers. Tier 1, implants and intrauterine devices, and we're gonna talk about these. Tier 2, injection, pills, action and ring. And tier 3, barriers and behavioral methods. This goes from most effective to least effective. Tier 1 is the most effective, tier 3 is the least effective. And this is a great resource. You can look at which has the percentage on the side of the contraception indicates the number out of every 100 women who experienced an unintended pregnancy within the first year of use. So out of 100 women, only 0.05% had an unintended pregnancy with the implant versus 24%, 28% just use spermicide. So a lot of different things to think about there. What are some standard contraindications? If they're pregnant, do not give them contraception. If they've had any current or past thrombosis or thromboembolic disorders, hepatic tumor or active liver disease, estrogens and oral contraceptives can be associated with several liver-related complications, so you need to take that into account. If they have undiagnosed abnormal genital bleeding, you're gonna make it worse with some of these, so you don't wanna give them contraception unless you know why they have that. any type of known or suspected breast cancer, and then any, of course, any allergic reaction to the component of the method. This is a resource. There was a, publication from the CDC, the U.S. Medical Eligibility Criteria for contraceptive use, which provided evidence-based recommendations for the safe use of contraceptives. They made updates in 2016. The last updates were made in 2019. These are very specific, like, oh, now you can use an IUD in high-risk HIV infection without restrictions, that kind of thing. So there's a website if you want to look at that, but that you don't need to know, it's just a resource, just so you know what was out in terms of helping clinicians make safe decisions or better decisions for their patients. The relationship between smoking and contraceptive use, this is a resource only. The higher the numbers, the more unacceptable. So 1, 2, 3, and 4, the range 4 is unacceptable. So in terms of smoking, if the patient is under 35 years old, there are no restrictions for use of the following contraceptives. The uterine, the copper ID, the IUD, the implants, but it does get worse with the combined hormonal contraceptives. And that's going to be the main category for all of these. There are more risks for the combined, meaning progesterone and estrogen, for those patients. And it gets higher the more cigarettes you smoke. So just know that there's definitely a relationship between smoking and contraceptive use and what you're not going to use in a smoker. Medical considerations, another resource, not going to go there. Routine exams, blood pressure, BMI, breast exam, pelvic exam, when it's essential and mandated versus when it does not contribute to, does not contribute substantially to safe and effective method use. So for combined hormonal contraceptive, you have to do a blood pressure on them first. For IUD, they have to have a pelvic exam first. So we're gonna talk about each tier. I'm gonna briefly go through this. Tier 1, our implants and our intrauterine devices. These are long-acting reversible contraceptive methods. You can see that down at the bottom, pretty small implant there. It's a plastic rod mixed with progestin. So we know progesterone and estrogen. We talk about our reproductive cycle. We know after that LH surge, which happens before ovulation, that progesterone and estrogen also go up, right? So what are we thinking when, so progesterone also maintains pregnancy, but it also is a birth control. How does that work? And we think through that. If your estrogen is, and your estrogen and progesterone are really high, just like it would be after ovulation, your body's kind of like tricked, like, oh, I'm pregnant already. And so, where if it's too low, you will have bleeding, menstrual cycle, right? That makes sense. So these higher levels, you're giving yourself higher levels,
Yeah.
it's kind of tricking your body
Like
into
makes
thinking that it's pregnant.
And like
So
water.
we are gonna use progesterone. And we're gonna use estrogen and we're gonna use combinations of those. So the next plan is an implant that is progesterone only. It works by thickening the cervical mucus and prevents fertilization. The sperm can't swim through, they can't fertilize the egg. Again, high doses, there's no follicular maturation in that secretory phase of the cycle, so there's no ovulation. It also causes atrophy of the endometrium or the lining, which makes a egg have a harder time implanting. These are great in terms of efficacy. That typical failure rate is 0.1%. We're gonna use these in patients who may be looking for a longer duration of use. This is approved for 3 years of protection. No evidence on long-term effects. Side effects, the most common and leading cause of discontinuation of an implant is irregular bleeding, and that is all over the place. That can be spotting, that can be amenorrhea, no bleeding at all, prolonged bleeding, frequent irregular bleeding, unpredictability. I was bleeding last week, I stopped, and then I started again, and then people just don't like that. So, that's one of the main side effects you need to do, like this is in breast cancer. Sometimes there's a local reaction where they implant it. Some people will also complain of headaches and weight gain. This is where you just take on your rotations or think about when you're doing, what are the advantages? This one's long-term, it's discreet, it's effective, and rapidly is reversible. Cost-effective, because if you pay for it up front, you're good for 3 years. You don't have to keep paying for it or getting it. Quick insertion and removal. You put it in any time during the menstrual cycle, you don't need a pelvic exam. And because it doesn't have estrogen, it is appropriate for smokers, 35 and older, as well as our breastfeeding moms. So implants, good for long-term, good for smokers, breastfeeding. Good for people who don't want to think about it. I put it in and I'm done, I don't have to think about it anymore. Disadvantage, somebody has to put that in, a trained clinician needs to insert it. The bleeding pattern, we said, is the most common reason they stop, and this does not offer protection against STDs or STIs. Counseling, you're gonna talk to them about the implant and how long it's gonna be in. It does need to be removed within 3 years, and a new rod needs to be placed at that time. You need to talk to them about the bleeding irregularities. They do need to use some type of non-hormonal backup, so condom the first 7 days after it's implanted, and then there again, no protection against STIs. These are things you're talking to your patient about. The IUD, a little bit different, also in our tier ones, was very effective, efficacy is very good. It is a T-shaped device that's placed into the endometrial cavity. There are 2 types in the US, the copper T388 or the Teragard, which is the most widely used in the world, and the levonorgestrel intrauterine system. So that's your Mirena, your Lolita, your Skyline, your Kyleena, those are commercials you're gonna see on TV. These are, also progesterone to prevent the fertilization, but the copper is the non-hormonal component, the non-hormonal option, which a lot of people like. We talked about the copper causing an inflammation in there, which the sperm don't like. We'll talk about these a little bit more. The progesterone works the same, just like with the implant, thickening of the mucus, atrophy of the uterine lining. Some IUDs can be used as emergency contraception, but IUDs are not abortifacient, so they don't cause abortion. IUDs have the highest satisfaction and continuation rate among patients. Again, put it in and forget it. For a little bit. There is a time frame with these. There are some risks. IUDs, there's a risk of uterine perforation when putting the IUD in. It can be exposed in a low 3 to 10% of patients within the first year. This is more common in nulliparous women. And there's a very slight risk of self-inflammatory disease within the first 20 days of use. Mirena was sued not too long ago because women were saying that the company hid the side effects and didn't talk about the risk of the product. They said that it caused the perforation that we talked about, organ damage, abnormal fluid buildup. They have settled all those cases. It is still on the contraindications to IUD for pregnancy. You can look through these. Similar to the previous unexplained uterine bleeding, breast cancer. If you have an anatomic abnormality of the uterus, you may not be able to use that. If you've got huge fibroids, you might not be able to get that implanted where it should be, depending on where the fibroids in the uterus or any other type of abnormality of the uterus. Advantages, you can look through these. Reduced risk of cervical, endometrial, and ovarian cancers. That might be something that women are interested in. The Mirena, though they were sued, they still, like I said, are on the market. They have been FDA approved for the treatment of heavy menstrual bleeding as well. So that may be something that is beneficial to the patient. May reduce menstrual symptoms in women who have uterine fibroids, so that's not to say you can't use them with fibroids, it just depends on where they are and how big they are, where they're placed. You can insert this immediately after abortion or delivery, you do not have any wait time. So mom can have baby and have the IUD placed right then and there. No estrogen means what? Who can use it? Smokers and who else? Breastfeeding moms, good. Disadvantages, again, have to be placed. Sometimes it's painful to place it. There's the risk of it coming out within the first year. There's higher expulsion rates in adolescents. No STI protection. Counseling, gonna go through these with your patient. We're not gonna go over all of these. Same thing. The time length on these is a little bit different. So we said the implant's 3 years, it needs to come out in 3 years to be replaced. With the IUD, the duration of action depends, and I think I left you a little list down there. For the copper IUD, 10 years. For the Marina, 7 years. For the Lolita, 6 years. For the Colina, 5 years. For the Scala, 3 years. So you have a longer duration of action, depending on which one, and it depends on, so a lot of these are the same. They're releasing the same hormone, but at different levels. So you can see down here with the Marina, it's 20 per 24 hours release versus 13.5. So the different ones have different amounts, and they're also for different sizes. So that Scala is a little bit smaller. So a woman who's never had a baby, that one might be placed versus the Marina, which is a little bit bigger. So it's different things. You don't, have to memorize that. Again, I want you to take this on your rotation so you can understand it. The takeaway, the Paragard, the copper is non-hormonal, and the levonorgestrel, which is your Marina, your Scala, is used in each of the hormonal IUDs. So for all of those I listed, the Marina, the Lolita, the Colina, the Scala, all those are levonorgestrel. Copper is toxic, think about that, causing inflammation. And then there are ones that you can use in emergency contraception. For the impact on bleeding, like we said, the Marina you can use for heavy bleeding. So that's a good option to think about for some of your patients. For some patients with the copper, they may have more bleeding too. Remember, it's foreign, so your body might not like it. They may have more bleeding too, so that's a side effect. This is on how to put in and take out IUDs, so look at that on your own. The tier 2, the injections, pills, patches, and rings, the most popular in the United States. The effectiveness is not as good as the implants and the intrauterine devices, but they are still relatively good in terms of use and prevention. So the first one is going to be your Depo-Provera, progesterone only, 3-month protection, inhibits ovulation. This is the only FDA-approved injectable at the time. So again, progesterone is going to thicken that cervical mucus, preventing fertilization. You should know that the most reported reason for this one, again, is menstrual cycle changes. And another big one for Depo is weight. I gained so much weight on the Depo. So those are things you need to think about. History of breast cancer, you cannot use it for that. So that's from even after 6 months, there can be irregular bleeding and spotting for 3 to 6 months. If they can get through the first 6 months, it might not be too bad. They usually have less bleeding, but that first few months can be rough enough where people are like nothing. Advantages, amenorrhea. Once you get through that first 3 to 6 month phase, that sucks. You might not have a period. So there, you don't have to worry about that. I can improve conditions, menorrhagia, dysmenorrhea, and iron deficiency anemia. Lacks estrogen, so our smokers and breastfeeders can use it. Disadvantages, you have to go every 3 months. Disadvantage, delayed return to fertility. It can take a little longer for them to get back to fertility. So you need to think about that. Okay, I'm family planning. Me and my husband, we just got married. We have a 5-year plan. And she didn't want to do this. We want to do this. So you need to think about which one you wanna use for them. Okay, maybe this is a good one for you every quarter. Maybe you wanna wait 3 years and maybe we'll try the implant for you. So those are things you should be thinking about. This one takes a little bit longer than the implant and the IUD. But again, pretty good in terms of efficacy. Counseling, same thing. You want to talk to your patient, look through this. Talk to them about weight. That's a big complaint about this one. Important to promote bone health because there you see a short-term reversible bone and mineral density loss. Is a disadvantage. This is short-term. Tier 2 also contains our combined hormonal contraceptives. So now we are talking about an estrogen and a progestin. These help also provide cycle control. So these are going to be our oral contraceptives, transdermal patches, and vaginal rings. Combined hormonal contraceptives, not going to go through the mechanism. As you know, we just talked about that faking of pregnancy, thinning of the endometrium, risk. Definitely you want to know. Risk for combined hormonal contraceptives, DVT, pulmonary embolism, reversible increase in blood pressures might not be a great option if your patient already has really high blood pressure. Or if they've had any history of the DVT or pulmonary embolism. They can sometimes cause melasma, which we saw in that mass of pregnancy. Over 90 brands. Don't expect you to memorize these. You should just know that what it is, an estrogen and a progestin, and how they usually work. So the patient usually takes so many pills and followed by a placebo. That would probably be the more common, but there are other options outside of that, like the gas, which you would take for 24 days and have 4 days off. 3 month seasonal and season 8 you can use for 3 months, and then Ligro is 12 months. Consistent. High number of unintended pregnancies because of misuse or discontinuation. Oh my gosh, I forgot to take my pill. I took it late. I doubled. I took another one. I forgot. I was taking it in a week, but I started again. Those little mishaps can definitely cause unintended pregnancy. They all require prescriptions, of course. Side effects are usually related to the estrogen portion of it. So the patient may have breakthrough bleeding, breast tenderness, nausea, bloating, some weight gain. A lot of these symptoms will disappear after the first few cycles. There may be a decreased risk of endometrial cancer with the combined oral. And a big one that a lot of people like, it effectively reduces acne. For some contraindications, it has estrogen. Smokers, can they use it? Not recommended. Postpartum breastfeeding, can they use it? Nope, not recommended. Our DVT patients, any patient with a known cardiac condition, not what you want to choose. The advantages for this is discreet. You can take them on your own. No one has to know that you take them. Easy to use, start and stop. Does require a prescription though. No protection against STIs. With this one, your patient has to remember to take the pill daily. So if they are not good with that, or maybe they're super busy, they don't have a normal schedule. I work nights this day, I work this day, I just forget, and that may not be a patient that you recommend this for. Cigarette smoking, I was supposed to push that earlier. Sorry about that. You don't want to use cigarette smoking. All right, counseling, adherence, the biggest thing you're going to talk to them about. Taking it consistently. You might want to give them a prescription for 3 months so that they can already have it ready to go. They do need to use condoms for 7 days. Quick Start is a method that allows women to start the contraception at any time during their cycle, and most people like that versus having, okay, I'm gonna give you a prescription for this. On the first day of your next menstrual cycle, I want you to take this, and with Quick Start, start at any time. I give it to you, I start it today. And a lot of people do a lot better with that, increase compliance. You want to use condoms for a week if they miss a pill or take one late. use condoms if they're on rifampin. Rifampin is so far the only antibiotic that is shown to interfere with birth control. What do we use rifampin for? TB. TB. Otherwise, you're safe to take, an antibiotic with these without a backup method.
That's such a big mess.
This is a resource. While passed in Maryland, state insurers are required to provide most forms of birth control without out-of-pocket costs for both men and women. Some of the key components of that Contraceptive Equity Act, women are able to get birth control pills and other contraception in 6-month doses rather than having to refill 3 months. So a lot of people will not have out-of-pocket costs in Maryland. Our POP, our progesterone only contraceptive pill called the mini pill, is another option. It's a good choice for women who can't use estrogen, but don't want an implant. They don't want an IUD. They want to take a pill, but they can't take the combined. This is another option for them. Again, just like the other pills, highly dependent on consistent use. With the progesterone only, there are no placebo weeks. You don't have a placebo week. The primary side effect of regular menstrual bleeding, so that's for most of these. Progesterone only is great, like we said, for smokers, our postpartum breastfeeders, no associated nausea. A lot of our combined hormonal contraceptive patients find a chill and sick to their stomach. It's a big reason also why people quit. I just can't take the nausea. So this may be an option for someone who you treated, who you gave initially a combined, but they came in with nausea, you can switch them to a progesterone. Counseling, pill is more than 3 hours late on a POP, they need a backup method for at least 2 days, 48 hours. You want to talk to them about the bleeding disturbances. Hey, I know it's rough, but in the first 2 months, after you get used to it, it'll get better. And then you can talk to them about that. No STI protection again. The combined hormonal contraceptive in the form of a patch. Transdermal contraceptive patch. So the patches are the Zulane and Twirla are the brand names. These are ethanol estradiol patches. They're applied once a week to a part of the woman's body, 3 consecutive 7-day patches with a single patch applied once a week, followed by a 1 patch free week per cycle. So put the patch on, wear it for a week. Put the patch on, wear it for a week. Put the patch on, wear it for a week, and wear it. After 7 patch-free days, they put on it and put it on the same day of the week. So you put your patch on every Sunday, put your patch on every Monday, whatever you do. And contraception. This one is slightly decreased. The efficacy is slightly decreased in women who weigh over 198 pounds. So that's something you might want to think about. For the lady, BMI is a little bit higher, weight a little bit higher. This may not be the most effective option, so you may want to think about some other options. But that's not all evidence. Some women use them well. There's some of the studies that show that it might be slightly different. Does have a black box warning for people who smoke and are over 35. Skin irritation might occur. Advantages, extra protection built in. If the woman forgets to remove her patch, she still has serum hormone levels up to 2 additional days. Potential for improved adherence. The disadvantages aren't the same as the combined orals. Skin reactions are a possibility. No STI. Those are the places you can place it: abdomen, buttock, right upper arm, upper torso. Do not put on breasts. Counseling, you can talk to your patients. We'll talk about vaginal ring. Let's take a 10-minute break. We come back. We'll breeze through the and progesterone, items. Treatments, we're looking at vaginal ring now. Brand name for this in our country is the NuvaRing. That's one of the more popular ones. It is a flexible, transparent ring placed in the upper vagina. It contains progesterone, and estrogen. Ovulation is inhibited for a 3-week period. It contains 4 weeks of hormones, which will allow women to leave it in longer, skip a period. It does not require fitting. It comes in one size fits most. Latex free, which is good. If you have any latex allergies. There is a 1-year reusable type called Anovera. Whereas the NuvaRing, you need to replace every month unless you're doing, well, you still need to replace it if you're doing continuous use, but with the Anovera, that is for 1 year. Same mechanism of contraception, kind of thicken the cervical mucus and suppress ovulation. The efficacy is comparable to that of the combined orals and the patch. You're gonna leave it in place for 3 weeks, followed by a ring-free week, or like I said, for continuous use, you're gonna skip the ring-free week, keep it in, and then replace it with a new ring at week, after week 4. At week 3. Same side effects as the combined hormonal contraception we talked about before. Expulsion may be an event that happens where it comes out. There can be an increase in vaginal discharge and secretions. Less than 3% of women discontinue use because of these events. Irregular bleeding is also uncommon. Some of the contraindications that might come along with this one is vaginal obstruction. If you have any type of vaginal obstruction, you may not be able to use it. And then people that don't like to touch down there, that is not a good option for them. Advantage, you put it in anytime during the menstrual cycle. Again, does not require special fitting. We'll talk about some things that do require special fitting. Extra protection if the woman forgets to remove it. After 21 days, her levels will remain her hormone levels will remain in the contraceptive range for an additional week. So even if she forgot to take it out, she's still protected for an additional week. Disadvantage, the increased vaginal secretion. Counseling, things you're gonna talk to with your patient. Hey, if your ring comes out for more than 3 hours, you may need to use a backup method, use a condom. You can remove it, but it shouldn't be removed more than 3 hours. If it does fall out, then you rinse it and put it back. Some of the red flags with our tier 1 and tier 2s. Things you need to be worried about. Patients complaining about persistent leg pain, lower leg pain, severe chest pain, sudden shortness of breath, any type of allergic reaction, weakness or numbness, partial complete blindness, new breast lumps, not sleeping, trouble sleeping, lack of energy, worsening menstrual bleeding, outside of what you'd expect at the beginning. I've had some irregular bleeding now. My periods are back on schedule, but they're heavier than usual. I'm really bleeding through. I'm bleeding through so many pads, that type of thing. You need to be concerned. Maybe you need to switch it. Maybe you need to look for something else with ultrasound. So our tier 3, remember, least effective, most effective to least effective. So this is going to be our least effective group, our barriers and behavioral methods. These are generally available without a prescription, so you can pick these up over the counter, with the exception of diaphragms. They are available when needed and for ongoing use. So I can go buy 15 condoms and I have it ready to go whenever I'm ready. I don't have to go to the doctor and get it, so a lot of people like that. Out-of-pocket expense is to the consumer. There's not going to be any prescription coverage for this, unless you're using the FSA card or something. Tier 3s need to be used at the time of intercourse, so it's not a, oh, let me put this, I got my implant, I'm good to go, or put my ring in on Sunday, and I have a big date on Wednesday. Still good to go with the tier 3s, you have to do it at the time. So that may be more inconvenient for some people. May also cause decreased use. Oh, you're in the heat of the moment, you're not gonna go get your condom, those types of things. With that, there's increased failure rate as well. Varying levels of protection from STI. So this is our only tier that will protect some from STI. The implants, the IUDs, the combined oral, those implant, the patches, the rings, none of those are gonna protect STIs, but some of the barrier methods will. This can be an added method. Maybe you use a ring and you still have someone use the condom, because of the STI. So this is an adjunct you can add on to. With the exception of male and female condoms, effectiveness is decreased, when combined. So you don't want to use a male condom at the same time as a female condom.
Interesting.
You don't want to use them at the same time. You put on his condom and you put in your female condom. Those are the only ones you don't want to work to do together. So we'll talk about the male condom. This is probably the most common barrier method. It's definitely the most common in the US. These are made from polyurethane, animal membrane, sheepskin, synthetic materials that fit over an erect penis. The condom prevents the deposition of semen in the vagina, so this is our semen blocker from our slide. The benefit, it does reduce the risk of transmission of STIs and HIV. No risk, no side effects, unless you are allergic, that's when you might switch to a different type of material. That would be the contraindication. If you're allergic to latex, you would not be able to use the condom. Advantages, it's over the counter. Don't need to go to the doctor, don't need to tell anybody, just pick it up and go. Easy to use, easily reversible. Don't have to worry about, well, will I be able to get pregnant in our 2-year mark when I'm ready? You don't have to worry about that because you are using condom, so you are controlling the timing with the return of fertility. Lower efficacy, that's the disadvantage, is our tier 3, so it has the least efficacy of the groups. And you need cooperation of a male partner for the male condom, and would like for you to wear a condom, which you find putting on a condom. You need them to cooperate with that. Counseling, you're gonna talk to your patients about the condoms, oil-based lubricants should not be used with latex condoms. So no petroleum jelly, lotion, baby oil, butter, or cooking oils, why that has to be. Why? But don't use those with condoms.
Margarine.
If it's margarine.
Margarine, yeah.
Oh,
I
Pam.
also want to talk to your patients about expiration date. Latex degrades over time, so average shelf life is about 5 years from the manufacturer date, so they don't want to use an old condom.
Can't believe it's not funny.
Excess heat and moisture damage over
Bless you.
time, so that's, we tell them not to store condoms in the car more than a month.
Or in the
Pockets,
wallet. Your wallet.
or wallet. Condoms been in there
Be
waiting for this
great.
time for the last.
The
We might need to take another.
Sean's not that bad here.
So,
Yeah.
the next type of condom is the internal condom. This is our female condom.
People.
Why are we 6 years old? This
So
never
there are
happens.
2 available in the US. One is made of polyurethane and the other of a synthetic nitrile. The FC2 is the only one that's FDA approved. Basically, there are 2 flexible rings. You can see it, that picture at the bottom. 2 flexible rings at each end. The inside is coated and the outside has you could do a silicone-based lubricant. During ejaculation, that condom will catch the semen. So this is our other semen blocker. Catches the semen and prevents it from entering into the vagina and the cervix. People of all genders can use internal condoms because it can also go into the anus. If you have a male to male sex, you could also use a internal condom, what we call a female. It can be inserted up to 8 hours before intercourse. So that's one advantage. You don't have to run and go get it. You can put it in and then go on your big date. Or whatever you're doing. It can be removed and discarded. It should be removed and discarded immediately. It should not be used again simultaneously with male condoms. You do not want to use those 2 together. advantages are listed, disadvantages. It may be noisy during intercourse, which may be annoying to some people. You do need to use with every act. Some people complain of vaginal discomfort. Some men complain that it irritates their penis. The next one is the diaphragm. The diaphragm is the one that we talked about is not readily available over the counter. This one you're gonna have to come to the doctor to get. So this is a shallow flexible latex silicone dome shaped device. We're gonna fill it with spermicide and insert it into the upper vagina to cover the cervix. That creates a barrier at the cervical opening. So that's gonna kill the sperm. You can see how it's placed, what it looks like placed on that picture. There are some real pictures of them at the bottom down there. This does require a prescription and a fitting. Women will have to be refitted after they have a baby, after a miscarriage or an abortion after 14 weeks. They'll have to be refitted if they have any type of abdominal or pelvic surgery or any weight change after pregnancy of 20% or more. So remember with this one, it requires fitting and you may have to be refitted. You do not need to know that stuff specifically. Take that on your clinic, take that on your rotation with you. This one, the female condom we say can be inserted up to 8 hours before. This one you can insert up to 2 hours before, but you have to leave it in place about 6 hours after. So that it can continue to work. Do not want to leave it in more than 24 hours after intercourse. Increased risk of UTI, increased risk of vaginal infections. So with this one, you put it in up to 2 hours before, but you have to leave it in for at least 6 hours after the time of intercourse. On the side folded, you'll see incidents of cystitis or UTIs, bacterial vaginosis, and vaginal candidiasis in women who use diaphragms. Good thing about these, just like the implant and the IUD, the upfront cost is there, but then it's a relatively low ongoing cost. Because after the initial fitting and instruction, you don't have to replace it. You don't have to replace it probably until about 2 years. Keep going to the doctor, that's another advantage. Disadvantage is it needs a prescription. You have to use it every single time at the time of intercourse. It's also a tier 3, so it's lower efficacy. And the bigger one with this one that we find in the clinic is a lot of people have a hard time putting this in. It's not easy. This is a special person that's going to use the diaphragm to try and fit it, put the spermicide, place it, make sure it's in properly, and then be able to remove it. So this is not an easy one to use. This is also not the one you want to use with someone who doesn't like to touch their hair. But you're gonna have to really get in there, put it going right above your cervix. So you really have to hit for gold. All right, moving on. The sponge. This is, look at the picture of it at the bottom. It's a small circular polyurethane sponge that contains 1 gram of spermicide, minoxidil 9 spermicide. So one side of it has the dimple, which you can see there, and then the other side has a little loop, which helps you to remove it. This remains effective for up to 24 hours after the last act of intercourse and should stay in place for at least 6 hours. So you put it in, its ingredients will last up to 24 hours. So this is the sponge containing spermicide. That's good for 24 hours, but it should be left in place for at least 6 hours. Do not want to leave this in place more than 24 to 30 hours. Toxic shock syndrome. This is what we talk about with toxic shock. When you leave your tampon in, it's sponges, diaphragm, those types of things. That's what you need to think about. That's sponge of it. So it's intended for one-time use. If a woman has had a baby, it may not be as effective. With this one, you need to moisten it with tap water to activate the spermicide. You'll squeeze it to distribute the spermicide throughout the sponge, insert it into the vagina with the dimple side facing the cervix. You want to keep the loop on your side so you can get your finger in there to pull it out. And then leave it in place. Do what you do. then it's remember to take it out. You wanna leave it in you wanna leave it in about 6 hours. Leave it longer than that, you fell asleep, and you woke up, just try not to keep it in more than 24 to 30. Side effects, some women experience vaginal dryness with the sponge, so that might be something that keeps them from continuing with that. Another insert, the cervical cap. So it's small, kind of like the diaphragm, placed right over the cervix. It's held in place by suction. So with this one, it has to fit very tightly over the cervix. It is more difficult to insert and remove than the diaphragm, so even harder to place. Again, personal choice. If someone wants to use this, it's gonna be a little bit tougher to use. Advantage, it can be used in women who cannot be fitted for a diaphragm. If maybe they have a relaxed interior vaginal wall, or by women who have had repeated bladder infections, because we said bladder infections, cystitis, vaginosis, bacterial vaginosis, and vaginal infections are higher with the diaphragm. So this may be an option for those women. I kept getting UTIs when I was on the diaphragm, so maybe you can switch them to the cervical cap if this is something they prefer. The most frequent cited cause of failure is dislodgement in the wrong place, not where it needs to be. And for women who have sex during their menstrual cycle, this one cannot be used during menses. Behavioral methods, there are a few we're going to talk about. So we're out of the products, the implants, the pill, the patch, the ring. These are behaviors we might do for contraception and family planning. The first is lactational amenorrhea, which is the most effective behavioral method. So after the mom has had the baby and she's breastfeeding, there is usually a pause in the menses. And she will not be able to have the baby during that time. Coitus interruptus withdrawal, which the patients are gonna call the pull-out method. To be frank here. Probably the most commonly used behavioral method. Okay. This conversation you have to have with your patient, so you have to get ready. They're gonna be very frank. I mean, I'll tell you, I was not even a PA yet. I was still in undergrad and I worked in a breast center where we did mammograms. I was like an assistant or something. I was just like a tech or whatever. But a lady was like, she found something, I can't remember what it was now, she found something, and then when I gave it to her, it's like a Cheeto under her breast, like, so, you know, you just see all kinds of things. So get ready for real life.
Should probably check that. Maybe they're not big enough to have anything stuck.
Cheeto there.
Maybe under my stomach fat.
I guess she was eating it, to go down her, didn't know, so when we took her.
Yeah,
that is the definition.
So
Later.
good. Like,
It's so good.
graduate.
And then the last one is fertility awareness, which is our natural planning. So we'll look at each of these three in the category. The lactation amenorrhea, that's the most effective of the behavioral methods, limited to women consistently and exclusively breastfeeding. So this is only effective if you're consistently and exclusively breastfeeding during the first 6 months postpartum. They will remain without a period. Ovulation returns before the first menses, so they won't ovulate. Coitus interruptus or withdrawal, frequently used, can work as well as some female barrier methods. So those, that show you the efficacy there. This requires a man to be able to recognize when ejaculation is about to occur and withdraw. So a lot of trust there. This again requires every active intercourse.
Love her.
Fertility awareness or natural planning. These women are
What?
using, there's a app called Flow, there's a bunch of different ones where you're tracking your ovulation. So you would, this only really works good when cycles are regular and you kind of know when it is, so you can kind of match, and you will be more likely ovulating, and when it's more likely that you'll get pregnant. Life expectancy of sperm can be 5 to 7 days, so they take all of that into account, using those calendars. This is an up-to-date, you can take a look at on fertility awareness-based methods. the possibility of pregnancy from intercourse on the days relative to ovulation as your. And a lot of those apps will give you numbers for you. I believe this is the last one, emergency contraception. Let's talk about that. Emergency contraception can prevent pregnancy after unprotected intercourse. So you'll see that abbreviation UTI. It works by disrupting the timing of ovulation or preventing fertilization of an ovulated egg. This is not an abortion-inducing drug we just talked about. So how do we confirm pregnancy? In one of our first lectures, what are 3 ways to confirm pregnancy?
HCG,
HCG,
ultrasound,
ultrasound,
fetal cardiac.
fetal monitoring. And what are we looking for with those? We need HCG in the blood. HCG, is it gonna develop if the egg isn't fertilized? Will you have a yolk sac if the egg isn't fertilized?
No.
Will you have fetal heart rate if the egg isn't fertilized?
Hope not.
So this is not an abortion-inducing drug. A lot of people confuse that. Emergency contraception is killing the baby. The egg has not been fertilized yet. So you're preventing the pregnancy. You're not ending the pregnancy. You're preventing the pregnancy. Okay? So that's important. So you can explain that to your patients. Some of these methods include, intrauterine devices. So we talked about copper IUD. You can use that as an emergency contraception if you're worried that you might be, that you maybe have unprotected sex and you're worried about pregnancy. And then there are morning after pills, our oral emergency methods. These are most effective when you take them as soon as possible after the unprotected intercourse, and ideally within 3 days, 72 hours. But some forms can remain longer, effective longer than that. We'll look at some of those. I think I left you a note for this one. You can look at that in your own time. These can be up to 120 hours after unprotected intercourse. Some of the name brands are Next Choice, Plan B, My Way. These are over the counter. Their effectiveness diminishes with time. The crystal acetate, which is a progesterone receptor modulator, the brand name is Ella. It does require a prescription, but it is probably considered the most effective of the morning after pills. This effectiveness does not diminish with time. And it may be more effective in overweight women, so that's an option for them. So let's say you're at day 3, at day 3, and you're like, oh, it might not work as good. This Ella will not diminish with the time like the Plan B. It disrupts the individual enough so that the implantation of the embryo does not take place. 75 to 84% effective in reducing the pregnancies from occurring. They do not harm an existing pregnancy. If you're already pregnant and you take it, it is not going to harm the existing pregnancy, but it will prevent one that has not occurred yet. With these, women will complain of fatigue, nausea, and headaches. And then we have our permanent contraception, of sterilization, the male vasectomy and the female tubal ligation or inclusion. So with male sterilization, this is a 15-minute procedure, probably. Various techniques, no scalpel in the US. This is the most common technique. Safe in office or safe minor office procedure done under local anesthesia or surgery center. Most effective form of birth control for men. Few side effects. And successful once there's no sperm noted 2 to 3 months on a semen analysis. Female sterilization, typically our tubal ligations are done most commonly at the time of delivery. So that deliver the baby. I've had non-tuplet mom probably said, I've had 9 babies. Go ahead and tie my tubes up. Not anymore. But yeah, so that's an option for women. If you are for sure you don't want more kids, then this is an option. There is a non-operative tubal occlusion possible via hysteroscopy. This disrupts the patency of the fallopian tube, so the egg will not be able to flow through the fallopian tube. We know the ampulla is where that happens most, and make its way where the sperm can fertilize and make its way then down to the uterus. But it disrupts that patency. There are more side effects compared to male sterilization with female sterilization. typically not, sorry, not. The increased risk of future ectopic pregnancies. With this one, it's effective immediately. Unlike the male, where you have to wait a couple of months to make sure that it's effective, with female sterilization, once you disrupt the tube, it's over. This can be done anytime, even unrelated to pregnancy. If a woman just decided, you know, she's not having a baby, but she wants the tubes tied, this is also an option. For men, backup contraception is needed until the patient has had at least one negative sperm check at 2 to 3 months, and after the procedure, and at least 20 ejaculations with no with the negative sperm check. Busy.
Busy.
Clinical world.
At least.
IUDs are the most common method of reversible contraception in the world, copper being the most common.
A sticker chart.
Tier 2 methods are the most popular. That's our injections, our pills, our patches, our rings. Inconsistent use is the most common reason why those fail. Common complications of the combined hormonals, DVT, pulmonary embolism, melasma, the skin changes. Tier 3s are, they provide adjunctive contraceptive protection, so you can use those, but which ones are we not gonna use together?
Condoms.
Male condom and.
Female condom.
female condom, or male condom and internal condom. Male vasectomy, less risky than female tubal ligation. Those are the. That's practice. All right, so assuming no sexual health is being discussed with the patient. The patient reports that she does not feel ready for a baby at this time, but is getting married soon and would like to consider pregnancy in about a year. Assuming no contraindications, which contraceptive would not be ideal for this patient? Vaginal ring, patch, Depo-Provera, or the combined hormonal oral contraceptives. And why is that?
Takes longer to.
Yes, delayed return of fertility. Good. Number 2, a 37-year-old patient presents to the family planning clinic to discuss birth control options. She has 3 living children and insists that she has no desire for future pregnancy. Which of the following methods of contraception has the highest failure rate? Bilateral tubal ligation, combined hormonal oral contraception, intrauterine device, or male condom?
Male condom.
Yes, question.
Can you repeat what the answer?
Number 1, Depo-Provera injection, C, because of delayed return of fertility. So for the highest failure rate, remember tier 1, tier 2, tier 3, except for tubal ligation, which is permanent. So highest failure rate for those is going to be a male condom. Intrauterine device, is that tier 1 or tier 2? One. Combined hormonal oral contraceptive, tier 1 or tier 2? Two. Bilateral tubal ligation, we said it's effective immediately. Once you disrupt the fallopian tube, you're not gonna open it back up and have a baby. So that one's permanent, so male condom. Last, you are providing contraceptive education to a patient that is 6 weeks postpartum and currently exclusively breastfeeding. Which option would be best for this patient? The vaginal ring, the mini pill, combined hormonal oral contraception, or the patch? Which one?
Mini pill.
Mini pill, why?
No estrogen.
No estrogen, progesterone only on the mini pill, the POP. Vaginal ring, combined hormonal contraception, and the patch all have estrogen. Good job. All right, quick, you can work on, look at these at home, but these are things I want you to think about when you go into your practice. Assuming no contraindication, which contraceptive method would you consider or avoid? So we talked about acne. Some patients might do combined hormonal contraceptive or combined oral contraceptive with those. If a patient's busy and admittedly forgetful, what do you not want to give them? What do you want to give them? What's those put it and forget it type methods might work best. If a patient has heavy menses, we know some cause amenorrhea that they want. Some are FDA approved for heavy menses. If they're a breast cancer patient, what do we not want to give them? Estrogen. Smokers, what do we not want to give them? Estrogen. Good. If they're worried about weight gain, Nick, what do we not want to give them? Hippo. Right? Hippo for hippo. That Nick.
That sounds horrible.
That's the way to remember it. All right.
Just-
Patient headed to the
That's
volunteer,
so sad.
patient headed to volunteer with the Peace Corps for 2 years. Do we want to give them, birth control that they have to come and get refilled every month, or every 3 months, or in Maryland, every 6 months? Maybe not, unless they're gonna get it mailed from their family or something like that. They want to try something that's longer, they don't need much follow-up. Patient says their CLC made them nauseated. What else can we try? Those are things I want you to think about. So when you're in practice, what you want to give. Any questions? All right, there are
Yeah.
30 some odd pages of resources for you to take on your rotation. Infertility is literally, it says more slides than it is. I'm literally doing like 10. So we're gonna do these and we're gonna get out of here, okay? I think there will be a treat. I'm tired.
Basics of time.
Does this presentation start? Literally 11:45, right?
Gross for real.
Yeah.
It's in here.
Yeah, on the schedule it says.
One of the
SQL.
best.
Fertility, we're gonna talk
I don't know
about.
if the second years are sitting in on it or not. I'm assuming not. If it's in here.
It's in here.
That's what the schedule says.
I would have
This is one of the
Lunch
add-ons. They
downstairs
said you didn't
after.
get much infertility and female GYN, so they're like, you gotta throw it in the spring. I'm like, okay.
It says
I believe I
11:45.
talked to
That's
Professor
two.
Jacob, he said he did talk about it in the male GU, so go back through your notes. You do have your end of year didactic coming up, so definitely go through that. I left you resources for those at the bottom of this, for male infertility, but our primary thought here is gonna be in terms of the woman. So infertility, it is defined as the inability of a couple to conceive within 1 year, or if pregnancy does not result after 1 year of normal, unprotected sexual activity. So couples cannot conceive within 1 year, or they have regular, unprotected sexual activity and no pregnancy occurs. That is what we think about with infertility. There are 2 types, primary and secondary. Primary is when they've never had a pregnancy. Secondary is when they've been able to conceive before, but now they cannot conceive when they're trying. If a female is under 35, you would work them up at that 1 year point. If the female is over 35, they could do an earlier workup for the infertility. Patients that are seen for infertility, those who, 25% of those couples will conceive within a month. 60 will conceive within 6 months, and 85 will conceive within a year. Those are just statistics, you don't need to know this. The primary causes of infertility, they can be from either partner or both. The majority of them are sperm disorders. Overall, an etiology for infertility can be found in about 80% of cases, but 15 to 20% of infertile couples will not figure out what's causing their infertility. And these are some of the primary causes: sperm disorders, decreased ovarian reserve or ovulatory dysfunction, tubal dysfunction and pelvic lesions, abnormal cervical mucus, and then those unidentified factors. When we have unidentified factors, those patients get a diagnosis of unexplained infertility. They call it unexplained infertility. They cannot figure out why it's happening. These are some of your sperm disorders. Sperm disorders are usually broken into 2 categories: sperm production and then the ability to emit, sperm emission. We're not gonna focus on this because this is an OB unit, but heat, substances, drugs, structural motility defects might be some of your production problems, the emission, retrograde ejaculation, ejaculatory duct obstruction, and some other things, congenital absence of vas deferens. Let's talk about the decreased ovarian reserve. So with decreased ovarian reserve, that's less than 10 follicles. Ovarian reserve basically is the number of ova in a woman's ovaries at a given moment. So normally, this is during childbearing years. Normally the ovarian reserve is between about 10 and 20. So if you have less than 10, that may be a sign that you have a decreased ovarian reserve. Less than 10 follicles or 10 ova noted in the follicle at one time. Ovarian reserve may begin to decrease at age 30. It rapidly decreases after age 40. Where men can pretty much be fertile for their whole lives, women will begin to have a decrease in the number of ova. That rapidly decreases after age 40. Ovarian lesions may decrease that ovarian reserve. Prior ovarian surgery may decrease that ovarian reserve. The workup, you would definitely want to do a workup in women 35 and up who are trying to conceive. Some of these people will have a poor response to ovarian stimulation. That's a treatment that they use to induce ovulation. Diagnosis, remember the FSH and the LH and all that stuff. So FSH, we need to stimulate the hormones. So you're gonna check on day 3, the level of FSH and the level of estrogen. Elevated levels of FSH and estrogen can reflect a diminished ovarian reserve on day 3 of the menstrual cycle. We can also check serum anti-Mullerian hormone, which is also made by the ovaries. This helps the eggs and the follicles grow during the menstrual cycle. So if they are not showing an adequate amount of that, they may be another indication of infertility potential, or show them their fertility potential, depending on what that number is. Transvaginal ultrasound is often used as well to look for viable follicles. The treatment, cryopreservation, so they're gonna freeze their eggs. They may try donor eggs from someone else, or they can try IVF. You know, all of those options, unless you have a friend with processing, still gonna cost, bigger costly. I used to work down the hall from Shady Road, and my coworker's sister was trying to have a baby. I think she said it was $17,000 for 3 days. So very expensive. They do have payment plans.
Insurance coverage has changed too.
I've
heard that, yeah.
She quit her job, because she was like, my sister quit her job, and I'm like, why? She said, because the government had IVF benefits or something. Because
Starbucks.
she did have a baby.
That's my brother.
So this is a lack of regular ovulation. So we know regular cycles are between 22 and 35 days, associated with ovulation. Irregular cycles are associated with reduced fecundity. I can't not say that. Fecundity. I said it yesterday.
What is it?
When I
The F word in that second line.
out loud.
Where?
Fecundity.
Yeah.
Something about it just don't sound.
Fecundity, yeah.
All right, regular cycles are associated with reduced fecundity, which is different than fertility. Fecundity refers to the biological capacity to reproduce. Versus fertility is like where you just are really. Every time. Yeah.
If we're going hard.
The diagnosis, the easiest way to confirm your normal ovulation is with serial urinary LH levels. The 12-day looks for normal intervals from the surge. We need to know about that reproductive surge, so it's looking for LH levels, a serial count of those. Previously, they used to check basal body temperature, but now it's more serial urinary. The treatment, you're gonna try to induce ovulation. You can do this with fertility drugs.
Right, doing like the ovulation cycle thing.
Ovulatory dysfunction. These patients may have oligomenorrhea, so you want to work them up for thyroid, hyperprolactinemia, PCOS is a big one. Tubal dysfunction and pelvic lesions. Tubal dysfunction, the fallopian tube is obstructed. Pelvic inflammatory disease is the most common cause. Studies have shown risk of tubal infertility in IUD users, double that of people that do not use IUD. Ruptured appendix, adhesions in the lower abdominal, from a lower abdominal surgery, any type of inflammatory disorder might cause inflammation within the tube, and then we know about ectopic pregnancy and where they implant, causing dysfunction, later on. Pelvic lesions, structural abnormalities that impede fertilization or implantation. Asherman syndrome occurs when scar tissue forms inside of the uterus. That is a possible pelvic lesion that may cause infertility. Fibroids can cause infertility. They can obstruct the fallopian tubes or distort the uterine cavity. You can have congenital malformations, endometriosis. Good diagnosis is the HSG, or hysterosalpingography, or hysterosalpingogram, which checks the fallopian tube. So 2 to 5 days after the menstrual cycle ends, they will use a catheter, inject the radiopaque dye, and then take pictures to see how that dye is flowing through the tube. If there's no blockage, the fluid will spill right on the outside part of the tube. Remember that picture from the beginning, how the fallopian tube has those membranes at the end and then the ovaries underneath. So that fluid's gonna go out of the tube, the body's gonna reabsorb it. And that we know it's patent and it's open. If it doesn't go through, then we know that we have a dysfunctional tube. There's a water-based dye that goes in first to prove patency, and then an oil-based dye that goes in second. That oil-based dye for some women can be therapeutic, so if there was a blockage, sometimes it will kind of help open that up. But laparoscopy finds 30% of unsuspected pathological conditions, endometriosis being the most common finding. Treatment, tuboplasty, which has actually been about 60 to 80% of patients where they go in and try to open up the tube. Laparoscopy for substantial adhesions or endometriomas. A lot of these women are just gonna have to try to do IVF for assistance, because if one isn't working and one is, then it's gonna be harder. Because you only have one fallopian tube and one ovary actually working, so they may need IVF to kind of help them out a little bit. You do have to be concerned for future ectopic pregnancies in these patients. If they do manage to get pregnant, unfortunately, they may be prone to ectopic pregnancy because of that inflammation in the tube. Abnormal cervical mucus. So the cervix should produce a thin, watery mucus that's very stringy and stretchy around the time of ovulation. They call sperm barket. This contacts and holds sperm for fertilization. So if a woman is not producing that, or it's abnormal, this may make it harder for the sperm to be held. You can test the quality of the cervical mucus. On day 12 to 14 of a 28-day cycle, they would touch the mucus with a pH paper and lift it vertically, like you see there on the demonstration. This is very specific. The mucus should thread to a minimum of 6 centimeters. I don't know who's measuring that, but that's very specific. The pH should be 6.5. Abnormalities may impair fertility by inhibiting penetration or increasing the destruction of sperm. For these patients, there is some correlation with nicotine and caffeine, so you want them to be able to produce a more watery, happy mucus, so you'll want to educate them on avoidance. If there is a cervical infection noted, you need to give them doxy, and you want to treat both patients if that's the cause. Another treatment is sperm washing and IUI, which is intrauterine insemination. The sperm washing is when they take the sperm, man has donated, take the sperm, separate it from the healthy swimming sperm, and then they implant it to make sure it gets there where it's supposed to go if they're having trouble navigating that route themselves. After sperm washing, the sperm specimen is placed high into the top of the uterus, close to the tubes in the egg, through a small flexible plastic catheter inserted into the cervix. So remember that we're going to talk about assisted reproductive You'll see why IUI is a little bit different than in vitro. So we'll talk about that more in a second. That's unexplained fertility, we said, is in 15 to 20% of patients or couples that we can't figure out why. They have a normal workup, you're testing everything, you just can't come up with a reason. You're testing the semen in the males, you're testing ovulation, you're looking at the fallopian tubes in the female, and you're not finding anything. Then you would consider that unexplained infertility. Fertility may be increased by stimulating the development of multiple follicles, so that's gonna be an assisted type of reproductive therapy. And we know assisted reproductive therapy can result in multi-fetal pregnancy.
Bless you.
Initial workup, you wanna get a good history. This is for male and females, where it applies, because males do not have a GTPAL. GTPAL, you wanna get that good obstetric history. You wanna know about GU infections, have they had surgery? Is there a possibility they may have adhesions? Appendicitis, and they had an appendectomy following, different things, fibroid surgery, removal, whatever. Some patients get lower abdominal surgery. Social factors, do they drink, do they smoke? What type of medications are you on? You're gonna do some labs, probably gonna test testosterone, you're gonna test FSH. If it's abnormal, you're probably gonna test LH and prolactin, you're gonna maybe check their thyroid, check their gonadotropin releasing hormone levels. These are our assisted. I don't need you to memorize these. I want you to be familiar with them. Unless you are going to Shady Grove, where I work down the hallway from, where they do these types of things all the time. You probably won't come across a whole lot of these, but you may have patients who have babies by these methods. So I want you to be familiar with them, not that I think unless you go into specialty, that you'll be actually performing, or seeing any of these, in your general OB/GYN rotations. But you should be familiar with them. In vitro, probably the most familiar. That's a fertilization occurring outside of the body, so they're going to, fertilize the egg, with the sperm outside of the body and then place it into mom. That's how my coworker's sister ended up having her baby. I we just talked about it, the fertilization happens inside the body, so they wash the sperm, get that good sperm, and implant it in, and with the there is gamete intrafallopian transfer, where multiple eggs are collected from the ovaries. The eggs are placed in a catheter with the sperm, and then they're injected into the fallopian tubes with laparoscopy. They're zipped just like GIFT, but it uses the IVF to place them. The eggs are mixed with the sperm in the labs. Fertilized eggs are returned to the fallopian tubes again via laparoscopy. And then there's ICSI, which is the picture over there on the side. This is where a female would use medication to stimulate the ovaries. The eggs are aspirated through ultrasound and incubated. And then the semen from the male, they pick the very best one out of the group, and they inject it directly into the egg. Again, these procedures are all very, very costly. I have a cousin, I don't know if I talked about her before, she had like 67 fibroids. They thought she had like 4 fibroids. And when they had surgery, they found 67 of them. Some of them were super, super tiny. They're like, but enough to have 67. And she had tried like so many of these things. I think she spent nearly $100,000 trying to have a baby. Nearly $100,000. She never did, but we did have our pup Dallas, who was the cutest dog ever. So that is her baby, and I hope nothing ever happens to Dallas. She will be devastated. So, yeah, in vitro and all types of assisted reproductive techniques are very expensive. There are people who I know specifically do, like I said, with my coworkers, friend, but also patients that I've seen specifically have a job for these types of treatments. They look for, do you cover these? They negotiate them in their negotiations for packages. I would like the coverage with this company if they provide this. And just keep that in mind. It's very expensive, not an easy choice for everybody. Our clinical pearls, infertility can result from one major deficiency or multiple, so it can be man, woman, both, could be multiple things at one time. Infertility in 40% of couples has multiple causes. Age substantially reduces the rate of conception. The older you are, the harder it might be to conceive. The HSG technique can have a therapeutic effect. 15% of couples have no explanation for the infertility, that unexplained infertility. The assisted reproductive technologies are typically a last resort for infertile couples, but can enable up to 85% to conceive. 85%. In your resource slides, I told you I'm gonna tell you about sperm, but I'm not talking about them. Not teaching them, that's not my thing. All right, so there's that for you. You do have your endodidactic, so take a look through those if you'd like. I have an OBGYN checklist